Here's where we left off, or where I believe we left off, and that is with the vertebral column. What do you need to know? Well, what's on this slide, all of this is testable material. There's 7 cervical vertebrae, 12 thoracic, 5 lumbar, 5 sacral that generally are fused, and 4 coccygeal, and they're generally fused as well, especially in the adult. Disorders. So you've heard probably of herniated disc. Now, discs that are herniated can be herniated in the sense that they're protruded. So in the center of the disc, there's a jelly-like substance called the nucleus pulposa. And that can tear through the annular fibers. The annular fibers are ligamentous-like. So the nucleus being jelly-like can squish through those if loaded, if there's a strong enough load put on or repetitive trauma to the annular fibers of the disc. And that nucleus then it gets squished into the wrong place, and that's called deranged. So the nucleus of the disc becomes deranged. That derangement can cause a bulge where the nuclear or the annular fibers have not torn completely. They're weakened. Part of the annular fibers are torn, and the nucleus pulposa is bulging posteriorward towards the spinal nerves or the vertebral column itself. This bulging stretches the outer part of the disc, the annular fibers, which happen to be innervated, and the bulging alone can be a pain generator. Now, that's a bulged disc. If the nucleus pulposa tears completely through the annular fibers, and the actual jelly-like substance of the nucleus pulposa has squished out into the vertebral canal or the intervertebral foramen, well, that's a ruptured disc, and it's protruded now. And that's generally something that's going to be surgical depending on how much of it's squished out and if it's symptomatic. Now, next, a kyphotic. Now, the thoracic curvature, which is a primary curve, the primary curves being the ones you are born with, the thoracic curvature, if it gets exaggerated, it is called a kyphotic curve or a kyphosis, whereas the spine is supposed to be in the sagittal plane straight up and down. If it's not, and there's a curvature to the left or to the right at any point, that's called a scoliosis. If the lumbar spine gets exaggerated in its curve, now remember, the lumbar curve is a lordotic curve. It's a secondary curve that develops as a result of crawling. So as an infant crawls, it starts to develop that lordotic curve or a lordosis in the lumbar spine. Now, if that lordosis becomes, or that lordotic curve becomes exaggerated, it's a lordosis. And compression fractures. I think you guys all know what squats are. So you load up a bar, you put it on your shoulders, and you squat with it. Well, imagine loading up a bar with like 600 pounds and doing squats with it. Well, you can actually create so much compression, downward force on the vertebral column that you can compress the end plates of the vertebra and they fracture. You can also take part of that disc, the nucleus pulposa, and you can create so much pressure that you shoot part of the nucleus pulposa through the end plate of a vertebra. And those are called Schmorl's nodes. and they're rather common. All right, moving on. Thoracic cage. The thoracic cage includes ribs, vertebrae. I think there's a picture coming up. There we go. So the thoracic cage, we have the ribs, the chondral cartilage. You see the sternum. Let me see if I can get a pen going again. Okay, you see the sternum here. The costal chondral cartilage is right here. So part of the ribs, as they come around, they're osseous, bony, but they do not articulate with the sternum as a bony structure. They articulate first to cartilage, and that cartilage articulates with the sternum. So the sternum is the central structure, which I lost my laser pointer somehow. So the sternum's here. The very top of the sternum, this structure is the manubrium of the sternum. And this structure down here, the pointy part, xiphoid process. That xiphoid process happens to be particularly interesting. I'll talk about that in a minute. But in the posterior, very posterior part of the thoracic cage, you have the thoracic spine. So you have the spine in the back that wraps around in vertebrae, meets cartilage, and then meets the sternum. You have 12 pairs of ribs. 7 of them are considered true, and 5 are considered false ribs. So the first 3 and the last 2, I'm sorry, the upper 3 and then the last 2, let me point here. See these guys? Whoop, going back. Okay, laser pointer, good. These ribs down here, do you see how they articulate with cartilage, but that cartilage does not articulate directly to the sternum? Because they do not articulate directly to the sternum, they're considered false ribs. So you have the last 5 ribs, the upper 3 of the last 5 actually do have cartilage articulations, and then the very last 2 ribs do not even have that down here. They're just floating ribs. They just sit back there floating. You do have to know the anatomy of a rib. Now you're looking at a thoracic segment here, and the thoracic vertebrae articulate with the ribs. So you see the head of the rib. This thing's not working well. You see the head of the rib, you see its neck, you see a tubercle on the rib. So the head of the rib articulates to the vertebral body, whereas the tubercle of the rib articulates to the transverse process of the thoracic spinal segment. You come around to the shaft of the rib, and I lost my pointer again. You come around to the shaft of the rib, and then you have the sternal end. Oh, anything else? Nope. The costal cartilage is what connects the end of the osseous part of the rib to the sternum. And then we have the sternum, and as we've already discussed, the sternum's body, the manubrium of the sternum is right here. This top part, it has a very distinct shape. Then you have the body of the sternum, and then you have the xiphoid process. So if you follow the bottom of your rib cage right to the center part there, the midline, you can feel your xiphoid process. If you were choking, or if you came upon somebody who was choking, you do the Heimlich maneuver. There's one thing with the Heimlich maneuver you have to be very careful about, and that is that you place your fists low. You place your fists down here, in this area down here, because if your fists get placed right in there, and you do a thrust right on that xiphoid, you can break it. And when you break it off, you can shove it right into the liver, causing internal bleeding and ultimately death. Shoulder girdle. Clavicle, collarbone, you know it as that maybe. Let's see if I can get this to work. So we have the clavicle here. You see that the clavicle articulates medially with the head of the manubrium, head of the sternum, known as the manubrium. The clavicle articulates laterally with the acromion of the scapula. We don't have, like, this wing structure in the back here is the scapula. Right here is the scapula. And that scapula articulates then with the collarbone, the clavicle, and the humerus, the arm bone. Let's look at the clavicle in particular. So the medial end articulates with the manubrium, the lateral end with the acromion process of the scapula. And then the scapula. We're looking at the posterior view here of the scapula. And, yeah. So I'm looking at this picture here. The most prominent feature is the spine of the scapula, and that's this structure here. It's the ridge that sticks out. If you were to palpate your scapula, reach your hand over your back, you can feel that wing bone. You can feel the scapula, but it's the spine of the scapula that you actually feel. Now, if this is the spine of the scapula, if you go above the spine, you have the supraspinous something. And if you go below the spine of the scapula, you have the infraspinous something. So if you can find the spine of the scapula, this is the part that sticks out that you can actually palpate, then the gap, the hole, the cavity that you feel right above that is the supraspinous fossa, and there's a muscle that sits right in here. And when you go below it, you can feel kind of in a space below it, and that's the infraspinous fossa, and there's a muscle that sits in there. You have the coracoid process, which shoots right through. If you were slenderly built, you could put your fingers, you could palpate just below the clavicle, and you go laterally until you get out close to the head of the clavicle, and right in there is a space, like an indent, that you can push your fingers in. If you wiggle your shoulder a little bit, you can feel the coracoid process poking out that fossa, that hole right in there. And then you have the acromion process of the scapula, and that articulates with the clavicle. Okay, the superior border over here. Superior border over here, medial border. Now, the medial border is medial because it's closest to the center line. So if you can look at the scapula in this picture, you can see why this is the medial border, because it's inside right there. You have the lateral border out here, the glenoid cavity. So the glenoid cavity is where the humerus actually sits. It sits right in there, in that cavity, fits right into it. Upper limb. We have the humerus, which is the arm bone. We have the ulna and the radius. Now, the radius, notice this right here, it says radius, and it points to this bone that's on the thumb side. So that shorter digit there is the thumb, and the radius is on the thumb side. The ulna is on the pinky side. The ulna is a little bit larger, longer, and a bit more prominent. And these bones are arranged so that they can cross over each other like this. It gives you controlled rotation of the forearm. Going further, below the ulna and radius, you find the carpals. And these are these small little oval-like bones. You have the metacarpals, which is the first row. And then you have the phalanges. There are 3 rows of phalanges. For the humerus, you have the head of the humerus, and that head of the humerus is what articulates into the glenoid fossa. You have the greater tubercle. There is a sulcus, a fissure, a canyon, like a small canyon gap that goes down, and it's separated by the greater and lesser tubercle, and that's the inner tubercular sulcus. There's an anatomical neck, which sits right here behind the head, and a surgical neck that sits below the tubercles. The deltoid tuberosity. It's a bump that sticks out on the lateral side of the bone. You come down here to the distal end of the humerus, and you have the trochlea. And you have the lateral condyle and the medial condyles, and they go by different names. Like I learned them as lateral and medial condyles. So the articular structure here, the white part that actually articulates then with the ulna, this part here is the medial condyle, and this part here is the lateral condyle. But they go by different names too. So the medial condyle can be called the trochlea, and the lateral condyle can be called the capitulum. Now, if these are condyles, these processes that sit above the condyles, epi above, so you have the medial epicondyle and you have the lateral epicondyle. You have the olecranon fossa here, and that's where part of the ulna will go into there. I'll show you that in just a moment. And the coronoid fossa, which sits right up in here. And I'll show you what fits in there in a minute too. First, the radius. Remember, it's thumb side, so in anatomical position, the palms are facing forward and the thumbs are pointing out. So in the anatomical position, the radius is actually the lateral of the 2 bones, while the ulna is medial. Notice in this ulna, you have this C-shaped structure where it articulates with the distal part of the humerus. You have the olecranon process, which forms the top part of the C, and the coronoid process, which forms the bottom part. So processes are sticky out things, and fossas are indents. I'm going to go back one slide. And you saw on the distal end of the humerus, you see the olecranon fossa. That's where the olecranon process will be seated. And you see the coronoid fossa, where the coronoid process will be seated. Olecranon process, coronoid process. You have the radial notch right here, articulating with the head of the radius. Now you look over here, you see the head of the radius, and where it's touching the ulna is the radial notch. Let's come down. we have the ulna on this side, you have the head of the ulna, you have a styloid process in an ulnar notch where the radius can then articulate on the distal end, and another styloid process over here. You have the radius, the shaft of the radius, shaft of the ulna. The radius bone does have a radial tuberosity. I think I covered all that. That takes us to the wrist. Now, you have 8 wrist bones, and they are irregularly shaped bones. They're arranged in 2 rows, and you have to be able to identify them. So, they're sitting right here. I think it's easier to find the distal row first, and then the others are on the proximal row. Keep them organized based on radius and ulna. So which bones are on the radius side and which bones are on the ulna side? Remember, the radius is on the thumb side. So you have the scaphoid, the lunate, triquetrum, pisiform, depends on who's saying it, hamate, capitate, trapezoid, trapezium. And then you have the metacarpals. So on the other side of the carpals, here's the distal row of the carpals, you have 5 metacarpals. And that's what forms the palm of your hand. So there's all fleshy stuff all around this. And then distal to the metacarpals, you have the phalanges. And these phalanges have 3 segments except for the thumb, which only has 2. It's called the proximal, middle, and distal phalange. Now I know the slide says phalanx, but I always learned it as phalange. And that brings us to the pelvic girdle, which we'll finish up on Thursday. Close that. Close that.